Welcome to the Pain-Free Athlete Podcast. I'm your host, Dana Jones. I am a certified personal trainer, and I'm here to help you achieve your fitness goals without pain. In each episode, I'll share tips and strategies that will help you stay safe and pain-free while you're working out. I'll also interview experts in the field of fitness and pain management. So if you're ready to learn how to stay active and pain-free, then subscribe to the Pain-Free Athlete Podcast today. Hi, everyone, and welcome to the Pain-Free Athlete Podcast. I'm your host, Dana Jones. Today, I'm joined by Dr. Trevor Turner. He is a nationally recognized physician specializing in regenerative orthopedics, biologic therapies, and performance-focused musculoskeletal care. As a founder of CartiNova, he works with everyone from elite athletes to military operators to active adults looking for minimally invasive alternatives to orthopedic surgery. Dr. Turner focuses on long-term joint and spine preservation to help people move better, heal more efficiently, and avoid unnecessary surgery. That was a mouthful. Welcome to the show.
We're going to try and make it harder for you next time, Dana. Thank you.
How you doing?
I'm great. Thank you so much for having me. I know obviously you have a history as an officer in the United States Army, so thank you for your service. And we're
You're welcome.
grateful to be able to take care of the men and women in uniform. Obviously, many miles of rucking and the many other activities that they're involved in sometimes take a toll on their spine and their knees. So we're grateful to be able to take care of those people when they need it.
I'm sure they appreciate it because back in my day, we didn't have that. It was kind of like, darn, you hurt. Keep going. So what drew you to rehab and physical medicine? Because, there's a pathway that it seems like doctors take and then they kind of branch off. And it seemed like you kind of jumped in right here with this. So what drew you to it?
Yeah, I think I got lucky in a lot of ways, just right place, right time. When I was in school, actually I got a grant to go work in pediatric HIV. And so I was working in Swaziland, which is a small country in Southeast Africa, and it was very meaningful work. It was profound work. It was very difficult. I saw a lot of people, unfortunately, young children especially, pass away from things that were very preventable in the United States. And that was very hard on me. So I came back and I certainly had a sense of renewed purpose to, kind of finish school and finish training. And I flipped a little bit, almost 180 degrees. So I went with something that was essentially, like a chronic care management model, right? Because HIV now is more or less a disease that if you're on the right medications, it's a chronic disease that you can treat and maintain for a long time. And so I flipped into something much more acute, which was trauma surgery. And so, when you're young, trauma is really exciting. It's fast paced. It's, a lot of course, risk involved. And so I did kind of some research in that and was working in that. And I had a mentor who was in his 50s, and he said, look, man, he was like, you think this is cool now? He was like, because you're in your 20s. And he's like, you can stay up all night and, you can not feel like death the next day. You've never seen these things before. And he's like, it's great. But he's like, when you're 50, he was like, it's not, and he
Gets
said, my
old.
wife, yeah. So he said, my wife works in this field, physical medicine and rehabilitation. He was like, she's super happy with what she does. She does really cool procedures. She helps people get better. She develops relationships with them. I really think you need to take a look at it. And so I was like, all right, well, he was a smart guy and a cool guy. So I listened to him, which was, not always my baseline of operations at the time. But so it just happened to be, I was so lucky that the president of the National Academy of Physical Medicine and Rehab was at my school, like in Texas. So grew up in Dallas, Texas. I went to school, medical school there at a branch of the University of Texas. And Karen Kowalski was like brilliant and also happened to be kind of specialized in burn rehab, which is a very kind of niche specialized field within rehab medicine. So the cool thing I got to work in the burn unit in the ICU, which again was kind of very hard work, but very meaningful work. And then I got to go work in the burn rehab unit. And so I got to see that whole continuum of like, well, this is what it's like when you're acutely resuscitating someone. And then this is what it's like in the long term when you help them find ways to live a meaningful restorative life in spite of this trauma that they've been through. There aren't that many places you get to do that, and I just kind of like, I feel like I totally got lucky. And so Karen, who wrote, a recommendation for me, was talking to me one day, and she said, "Listen, there's over 120 medical specialties in the United States. You've got to figure out people that you want to be around. You got to figure out something that you like to read about, and you got to figure out a kind of exam that you like to do."
Mhm.
And I was like, okay, so, I liked the kind of doctors that went into physical medicine or rehab were like a little easier to talk to. And oftentimes they didn't feel the need to be the most important person in the room. So I kind of liked that off the bat. And that's, a little different from trauma surgery. Like those folks are awesome at what they do, but they kind of walk with their heads held high for a good reason and, feel like they are very important. So I like the personality and the attitude. I loved neurology and I loved orthopedics. And I liked reading about it and doing those kind of exams and those things kind of matched up. So I had the opportunity then to go work in different places. It's an old school type of residency where you do a separate internship for your first year, and then you do your residency after that for 3 years, and then you do specialty training afterwards. So I got to go work at UC San Francisco and do surgery for a year, which was awesome. It was a very challenging intern year. It was a great time. Then went into rehab medicine for the next 3 years. It was a very, very big change from a cultural standpoint because I came from San Francisco to Birmingham, Alabama, which, you can just imagine are kind of very different.
Little different.
Yeah, political affiliations, kind of just cultural, rooted in the deep South versus a lot of people in California we're from all over the world. But um, there were beautiful things about both of the places, and understanding how people solve problems in different ways was really critical. And I got introduced to somebody while I was in Birmingham named James Andrews, and if you follow kind of professional sports, you watch ESPN. There's a lot of people who have injuries and they go to see him, or members of his team, basically for second opinions or for surgeries or whatever. And so I was grateful to be a part of that because it pushed me to a level that was really, really high because, I showed up there and worked with them for the next 4 years, and, there were just no off days, right? I mean, when you are taking care of people at a certain caliber, the service that you provide for them is sort of kind of never ending, right? So you have to always be on call, you have to be professional, and you have to oftentimes extend beyond, what it means to just work in a clinic. And I watched him do that, right? So I watched my kind of boss or mentor, just give his cell phone out to people. And I think in a lot of modern medicine, people are like, there's always walls, right? Like there's walls with insurance. You go in the clinic, you don't get the doctor's phone number. You can maybe message people through a chart, but like maybe they're checking the messages, maybe they're not. Maybe they'll get back to you in 3 or 4 days. And that was just not the old school sort of practice of medicine that I got to witness firsthand when it came to the customer service part. But then the innovations part was also awesome. Dr. Andrews had kind of like made numerous discoveries. He pioneered like a lot of new ways to use medical devices to repair the labrum and how to do arthroscopy, like all these things that are now just complete standards of care. But when he was doing it, he was kind of like, among the first to do it. And so a lot of people now, when they talk about him, they're like, oh, yeah, that guy's like, on the Mount Rushmore of orthopedics, so to speak. And so I was just privileged to kind of learn from great people and at the same time look at things that I thought could be done better and start thinking about how to do that at scale. So,
Well, that's a great experience because you got the opportunity to see people from almost start to finish. And a lot of
totally.
times, I think in the other aspects of medicine, you don't, right? I do the surgery, do a follow up, see you later, and you're not seeing the rehab or the challenges or anything that kind of may occur during the recovery process. And so I guess my next question is like, now through all this experience, what have you learned about how the body heals?
Yeah. So we had a huge duality going on when I worked with that group. So we had a combine training facility for the NFL. So on the one hand, we would have these incredibly elite athletes, and some of them were already in the NFL and they were injured, so they were coming down to train or rehabilitate. Other people were competing to be first round draft picks and whatever. And so they would come train at this facility, and Exos was the name of the facility. It was right next to our clinic. And they would have this team of people. So we would get to be their doctors if they had some kind of injury and they needed help. But there would be a human performance coach and a massage therapist and a nutritionist and a sports psychologist. And so, it was this incredibly team based, multifaceted approach to care. And of course, you know, the level of that care, because the team was so strong, was fantastic, right? And we had a really cool program, a grant program called the Eagle Fund, where if you were an injured special operations personnel and you were hurt, but you were, maybe you're rehab, but you weren't really ready for what we call operational duty fitness, they would come down and train as well. So these people, were Force Recon Marines and Navy SEALs and Army Rangers and Air Force PJs and parajumpers. So, and their ethos for how they would train to rehabilitate was very different, right? Because
Yeah.
there wasn't like millions of dollars of contracts on the line, which obviously motivates people,
No, but
but
it's
it
a
was
job.
like yes, and it was like their commitment to the people that they oftentimes considered their brothers or sisters or however you call it was extraordinary, right? And so you could see them do things and push through things that maybe somebody like me who wasn't a special operator and wasn't a professional athlete, imagined that some people were capable of. And then the duality was we had a cool community in Pensacola where this clinic was, and cool people that I liked seeing and I liked hanging out with and I liked fishing with and doing stuff that people like to do in the Gulf. But a lot of them could not afford or could not come into clinic for the same types of care resources, right? So then I had this horrible dilemma, right? Or I had this ethical problem or moral problem or whatever you want to call it, professional problem, where we'd say, okay, well, on the one hand, I know how to give you what we would consider the best or the most elite type of this care in the country, but care was being rationed on people's, insurance company or even the inability of them to afford or have insurance, or let's say they have insurance, but their deductible was $10,000, $12,000. So then it was they're basically paying cash anyways, right? At that point for their health care, unless you have cancer or an organ transplant or whatever. So, it forced me to really reconcile with like, well, how can we, do this at scale for people who need the help and deserve the help, but maybe, don't have access or don't have a mechanism to do that. And so over the years, some things have changed that have really helped. Like I think the wearable data movement and fitness movement has been huge, between all kinds of sleep trackers and glucose monitors and ways that we can look at heart rate and recovery and HRV and strain. And that has really helped democratize, I think, some of the things. And then some other things that sort of just got cheaper as time went on. 2007, I think the first like, human genome sequence or whatever it cost, tens and tens of thousands of dollars. And I think the first guy who ever did it paid like, $10 million dollars for it or something. And now we're doing that for 300-400 bucks. So, which is, I mean, that's money that you have to spend, but it's money that, and what I feel like is money well spent because it can give you such an advantage in the way you personalize your care. Um, and so the other kind of revolution that was going on at the same time is what we call regenerative medicine. And so I was hugely skeptical about this in the beginning because, I saw these people flying in to come get, either a fancy surgery done or maybe try to avoid surgery and have a fancy procedure to eliminate the need for surgery, which kind of became, what I found my passion doing. And so they would pay all this money to get either something we call PRP, which is platelet rich plasma. And a lot of your listeners, it sounds like, probably already know about that. And I think you had an expert on your show who talked about that before. Stem cells they get from different places, whether it's bone marrow or fat or some other kind of, graft is what we call it. And, they were paying out of pocket for it. And so I was like, well, geez, they're already coming in and they're, paying all this money to have their surgery done. And now they're paying on top of it to get, these quote cells put in. And I was very, very, reluctant to accept that in the beginning. And I started to see some of these people back over time. And I was like, well, gosh, like not only are these people getting better, but they're getting better either number one from things that they didn't get better from before, or two, they're getting better for longer than we would anticipate if we just said, okay, well, you had this injury, so I'm going to send you to PT and I'm going to give you an NSAID, non-steroid anti-inflammatory drug like ibuprofen or something. Or, here's a steroid shot, and oh, when that doesn't work, you can go get surgery. And it's just like, okay, like there has to be a better pathway than this, right? And I think the nice thing about patients who, over time, it seems like more and more people have committed to advocate for themselves, right? And so they're refusing to accept the status quo of like, okay, well, I'm just going to go and fail 6 to 8 visits of PT, and I'm going to pay all my copays for that, and I'm going to take these 1 to 5 medicines that don't help me so I can finally get my MRI, and then I'll go get a shot, and then I'll go get a surgery. And people are like,
It's all a
no, like,
game.
yeah, they're like, this is dumb and I'm not going to do it. And the other thing is because I love helping startups and entrepreneurs and small business owners, is I meet a lot of people who are successful, but they may not have big corporate healthcare benefits. So like I saw a guy, in the last couple weeks, he owns a landscaping business, and he doesn't have a big time healthcare insurance plan, but he makes pretty good money because if he goes and does, 2 or 3 landscape jobs, like he gets paid for that, and that's pretty good. And he had a very bad experience with the orthopedic surgeon that he saw. He had a rotator cuff tear. He needs help. He can't take the time off to have a 12-week rehab because if he does that, there's no way he can go do the landscaping job that feeds his family and does everything else. And so having the opportunity to offer him an alternative where we said, listen, like, this is how many centimeters your tear is. It responds fantastically to a minimally invasive ultrasound guided graft that, by the way, we can take from your fat tissue, and not to, be crass about that. But most people, if you say that, they're like, well, take as much as you want, take some extra while you're at it. Right. And, he's back at work within a week and he's doing significantly better than he was when he came in. And he's not totally healed, but over the next 6 to 12 weeks, he'll do outstanding. And then he won't have to miss all the time off and all the income and everything else that he would lose if he had a major surgical recovery. Right. And so um I think people come in and they have different whys for who they are and what they do. And it doesn't matter to me if you're trying to win a national championship or if you're just trying to pick up your grandkids, off the couch or stand up with them. I think everybody has their own why. And I think the ability for us to restore mobility and movement for people is such a profound connection for what it means to be human and what it means to find your identity, that it's kind of like a very sacred thing for us to be able to do with someone.
What are some of the myths that, or even overpromises that regenerative medicine kind of gets, like bad labels possibly through social media and just, the billions of fitness experts out there that don't have medical degrees?
Yeah, I think we have really struggled with that over the last 10 years. And so some people have said, well, I don't want to use the term regenerative medicine because either it's not accurate or I don't want to be associated with, this person that popped up on the corner that's doing something that I find questionable. And then people said, well, if you work in sports and orthopedics and, you have a board certification or you have training or you have expertise in the use of ultrasound or x-ray, we're going to start calling it something else. We're going to start calling it orthobiologics, but then other people started using that term. So I think for me, one of the big things is data quantification or just measurement. Right. So if I see somebody who comes in the clinic and they're interested in a procedure, or they'll say, hey, I had this done somewhere else and it didn't work. And let's say I diagnosed them and I'm like, wow, that really should have worked for what your problem is. And I say, well, how many cells did you collect? Or how many platelets were in your PRP sample? Or how many cells were viable out of your graft? And I think unfortunately what we found is, probably, gosh, I don't know, 99% maybe of the people who do, or offer procedures like this either don't use any kind of imaging guidance or they don't have any method to measure the number of cells, right? But we've seen as we keep outcomes data that that makes a huge difference. So if I know that you're 70 versus 50 versus 30, the number of cells that I'm going to concentrate in order for someone to have a good outcome are very different. It's also different depending on the joint or depending on the tendon or the ligament or what it is that you're trying to treat. So all those things kind of require personalization. And I think that was a big reason that we kind of launched or started the company that we did to be committed to that. And, it's a lot more expensive to do it that way. But in my
Mhm.
opinion, if you're going to come in and get a procedure done, my goal is that you get the procedure done once, right? And you're not coming back because you failed two or three or four or whatever it is, right? And so, we have an obligation, I think, to the patients and to the people of, the United States or the people of whatever country are coming to see us to do the best possible job that we can for them to ensure they have a good outcome. And so I think the data really matters. And then I think, I get this question from people, and this is a good sort of segue. So the people will come in and let's use knee arthritis because it's a common example, right? And they say, okay, well, we grade knee arthritis, 0 to 4. And 4 usually means, you would traditionally go get a knee replacement. And, a 0 or a 1 is very mild. We usually don't see those people in clinic. We usually see twos to start and then threes and fours. And we'll talk about different options and there are certain efficacy or power to doing injections with cells that we get from bone marrow or fat compared to just using cells from blood like PRP. And they'll say, I have these problems on my MRI or on my X-ray. And if I come back here in 6 months to a year or sometime in the future, is my MRI going to look different? N-
Hmm.
In full disclosure, most of my patients don't get follow up MRIs because they get great results and they're happy and they don't come back and get new scans, right? Most of the time, people get MRIs if they're hurting or they're suffering or they're not doing well. So, and it is different if you're paying insurance versus cash, honestly. Some people are just like, I don't care. I just want to see. But we saw people who would get great clinical results and they'd be very happy. And they're like, I don't care. I just want to buy an MRI because I just want to see. And they'd come back and we'd look at them and their MRIs really didn't look a lot different. So, this notion of
Hmm.
like, I will give you a stem cell and it will grow into some kind of new cartilage was obviously flawed, in my experience, right? And I've been doing this about 10 years, so you can find people more experienced than me, but you know, we've had very good results, which is why people come and see us. And we're honest, which is why people come see us, I think. But, so, the other way of thinking about why this works is there's like, okay, there's this theory called differentiation, right? Which is this idea that I give you a stem cell and it turns into something new and it turns into bone or cartilage or fat or tendon or ligament or whatever. Right? And that is one theory of how things work. There is another theory, which in my mind, based on my experience, seems to be the dominant one called immune modulation. And so it's this idea that if we think about the underlying biology or the cellular biology of what's going on, we have to change that in some way from something that is catabolic, meaning it's breaking things down. And we need to change that biology to something that's anabolic, that's building something back up. And so I think the signaling molecule that your body gets if you get a great stem cell or PRP procedure is that it's telling your body and your immune system something is broken here and you need to come fix me and you need to do it now. And I think the other question is in medicine, we see people come in the clinic and you can see somebody with an MRI who's about the same age and gender as somebody else. And one of those people is going to have a hard time walking up the stairs, and the other person's going to be doing a triathlon. And the question is, why can that exist if these people have the same apparent structural problems? And in my mind, the answer to that is, well, their underlying cellular biology is very different. And so we have to be committed to figure that out and study that. And it's very simple to say, well, if you're insulin resistant diabetic and if you're obese and you're sedentary and you smoke, Like your outcomes are going to be bad. And if you're
Mhm.
young and healthy and you exercise all the time and you don't smoke, like your outcomes are going to be good. And I mean, that's an oversimplification, but it's generally true, right? But I think it's a lot deeper than that. And as we started to look way beyond the surface and say, how do we understand genomic instability and loss of proteostasis and altered cell communication and hormone signaling is a huge part of like, gosh, if we take someone who's hormonally deficient and we give them a procedure versus somebody who's, either their hormones are well balanced or let's say they're on hormone replacement therapy, like their outcomes seem very different, right? And so in a positive way, basically. Like, should we be taking that into account for everybody that we see, right? And my answer to that is yes, like we should be. And I think it's just hard because people say, what's a sports medicine doctor doing trying to understand key drivers of fundamental inflammation that really sound more like precision medicine or functional medicine or whatever you
Mhm.
want to call it. And I say, well, here's the thing. The easiest part of sports medicine is probably the orthopedic part. And don't tell that to all the surgical friends or colleagues maybe you have, but the hardest part is the team physician part where you get on a plane to fly to a tournament in Asia and a dude throws a blood clot for some reason. You have no idea he had an underlying mutation or
Mhm.
von Willebrand factor, whatever. Like that's the hard part, right? And so there is a tremendous amount of, I don't know if you call that primary care, but you call it, just the real maybe practice in medicine that is not just, well, I'm like an ortho bro who like throws hammers. So I think it's a huge component to what we do. And then the next question is for that same thing I said, like, well, if my MRI doesn't look any different? Why do I get better? It's well, how do we make that better? And that's really sort of where CartiNova evolved from because as we started to see this human clinical trial data come back for this fractional laser that we started to use, now all of a sudden, 6 months out, you saw a guy who looked like, or a lady, or, a patient who had, advanced stage 3 or 4 arthritis, look like his arthritis was a stage 2 or 1. And that's not a thing we see happen in medicine, really, right? Or as an alternative example, a spinal disc, right? Most of the time you come into the
Mhm.
doctor, you got back pain, you do all this stuff, you get an MRI. Oh, you got black discs on your MRI. Oh, you got degenerative disc disease. Well, like so does everybody, right? And I'm 41, so I'm not a spring chicken, but I still like to do Olympic lifts and work out hard. And I herniated my first disc when I was 17, and somebody told me I was going to need neurosurgery, but I didn't want to have surgery because I was young and I was worried about the outcomes. And thank God, knock on wood
Which
now
was
that I
right.
that I didn't, and actually then 5 years ago, like got multi-level PRP injections in my spine and like, got back to CrossFit, did great. So like very happy about that. But I think it would have been so easy for me, like as a physician to be like, oh, well, let me just go wherever like this person sent me to therapy. And if that didn't work, I'll take these pills. And if that didn't work, I'll get steroid injections. And if that didn't work, I'll go get surgery. I was just like, but man, like I don't want to do that. Right. And the data and the evidence now is better than it used to be. So in the clinical trials that actually this Russian neurosurgeon, which you can imagine was not an easy person to talk to, but he had done over 4,000 cases where they'd used this laser called the Regenerative laser, and it inserts through a tiny, like an 18 gauge needle. So if you look at the actual point of the Regenerative laser, it's smaller than the tip of like a paper clip, right? So very, very small. So people are getting this done with oftentimes zero sedation, just local anesthesia. Or
Crazy.
sometimes for complex cases, we're giving people some sedation to do it. And you'll meet some people who are like, listen, if you're gonna do something to my spine, like I don't want to see you walk in the room without giving me sedation. Right? And I'm
Right.
like, well, that's okay. You get a preference for that, I think. But We've seen now 5-year outcomes data that have shown that discs that were otherwise totally black on an MRI, meaning they were degenerative and they'd lost sort of all of their water, lost that kind of jelly center that gives them that nice cushiony kind of elasticity between the bones. We've seen, new sort of white collagen signal on the inside of a disc, which is just wild. Like it's wild for me as somebody who struggled with, I mean, really like 20 years of off and on like back pain and sciatica and stuff, like personally, and somebody who didn't want to quit doing triathlons and kickboxing and deadlifting. And, I mean, most people would just be like, we should just quit doing all that stuff. Right. But I'm like, but I don't want to quit doing those things. Those things give me meaning and purpose and they make me happy. And I like the fact that, I've got an 8-year old and now a younger child who's 6 months old. So I'm like, well, man, by the time she graduates high school, I'm going to be like 60 years old. So like, I want to be like a rocked up 60-year-old because if she wants to go
There you
climb
go.
Kilimanjaro, like I want to go do that with her. I don't want to say, well, sorry, like daddy's back is hurt. He can't do that with you. That's the lamest thing ever. So
That's awesome.
anyway, so
Well, Trevor, thank you so much for sharing all that information with us. How does somebody get in touch with you if they want to learn more about the services that you provide?
well, thank you for asking. Yeah, so we do have a website, www.cartinova.com, and we have a email you can send cartinova at proton, proton .me. And we have a great team who sees people both in the Atlanta area and people who fly in for care. So we have a medical travel coordinator who will do flights, hotels, transportation to and from the airport. So it's important to me that that's not a limiting factor for people who are great candidates who have knee arthritis or spinal disc issues that are looking for non-surgical options.
Thank you so much.
Thank you, Dana. I appreciate all your time and appreciate what you do for the audience that we see.